Good evening and thanks to everyone for joining us today. We welcome you to the webinar today organized by Haryana chapter of ISAR and technical partners for this webinar series, NAARI and FemBon division of Jagsonpal Pharma, makers of Cystilia M, Divertone and Divertone SR 20 mg and Lycoride M tablets. So, dear doctors, we present you Cystilia M formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Moving ahead, we have Divertone SR 20 mg, micronized and sustained release tablets of dydrogesterone to improve compliance and enhance outcomes. Divertone 10 mg tablets also available. So next we have Dr. Lycoride M, tablets of natural lycopene fortified with N-acetylcysteine, enriched with CoQ10 and L-carnitine for added advantage. Lycoride M contains two proprietary complexes, natural lycopene as lycobids from Israel and L-carnitine and L-tartaric acid in ratio of 2:1 to give highest available L-carnitine as Carnipure source from Switzerland. So with this, a warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. So now we invite Dr. Jyoti Malik, Chairperson Haryana Chapter ISAR and Director Roots IVF at JJ Institute of Medical Services, Bahadurgarh, to kindly initiate the program. We welcome you, ma'am.
Thank you so much. Thank you, Mr. Dr. Devkant Tyagi, and welcome to this platform. Also welcome Nimisha from Jagsonpal. I think you are the new team, and I think Dr. Deepika is guiding you and giving over to you for the future webinars. And thank you so much, Jagsonpal, every time for being there. I know the new team would also be equally good, though they'll take time. And I think Dr. Deepika is always there with us for our meetings, and the new team would learn as fast as she does. So coming on to our Inspire Ignite Series 14 today, and this time today, with the blessings of our National ISAR President, Dr. Amit Patki sir, and our Secretary General, Dr. Asha Bakshi ma'am, we bring to you this series on mastering IVF. And we at Haryana ISAR, with our motto of Prayas Evam Vistar, are constantly doing such webinars every month and also twice a month. So today we have this topic on mastering IVF, where we have I have already taken blessings of Dr. Amit Patki sir, who is Medical Director, Fertility Associates, Mumbai, and also he's consultant at Khar Induja Surya and Khar Mumbai. And sir is our national president and is always there for our for every support that we need at our local level of ISAR, Haryana ISAR. Then we have Dr. Asha Bakshi also. The next slide, please, for Dr. Asha Bakshi's CV. Next one. Dr. Asha Bakshi is from Indore. Can you move the slide, please? The next slide. Okay, so we have always Dr. Asha Bakshi, who is with us, constant hand to hand in support with Dr. Amit Patki sir, and she is always there for guiding us and for any of the issues that we have at our levels. And with our local team of Haryana ISAR, the Secretary, Dr. Meenu, Clinical Secretary, Dr. Manju, and our Treasurer, Dr. Lakshmi, we are a team which is really trying to put our best foot forward every time, whatever we do. So today we have our first, today the talk is on something which is very, very difficult and a different topic. surprises at IVF. And for this, our speaker today, in fact, Dr. Sachin, I'm sorry to say that he was not well today morning and he could not join us. But definitely, Dr. Saryu is there to give the talk on this topic. Would be talking on the surprises at IVF. And for this, our chairpersons are Dr. Neeru Thakral, Doctor from Gurugram. She is the president of Gurugram Obs and Gynae Society. She is the secretary just now, and she was the vice president of the Haryana Endoscopy Society. She is also the director of the Morpheus Thakral IVF and Thakral Hospital, Gurugram. Then we have the next chairperson, we have Dr. Manju Khurana, Director, Chief Infertility Consultant, Gobid Fertility Center, and she has been the past president of the Haryana chapter of ISAR in 2018 to 2020. Next, we have our next chairperson. We have Dr. Manju Dagar, who is the director of Nestlings Gynae and Fertility, and she is ex-HOD W Pratiksha Fertility, and she is presently the clinical secretary of Haryana ISAR. Next, we have Dr. Meenu Handa, who is the secretary of Haryana ISAR and also the clinical director of and unit head Cloud9 Hospital, Golf Course, Gurugram. Then last but not the least, we have our next chairperson, Dr. Lieutenant Colonel Gurneesh Singh, who has been professor of the Maharaja Agrasen Medical College, Agroha, and he is presently the president of the Hisar Obs and Gynae Society and has a vast experience. So if Dr. Gurneesh, sir, could you introduce our speaker? Dr. Saryu Mohita is our speaker today. Dr. Sachin Kulkarni was not well, so Dr. Saryu would be taking his talk.
Thank you, Dr. Jyoti. I will like to invite Dr. Saryu Mohita. She is fertility consultant at Jehangir IVF Pune, at Novo Solitaire Care Khadi Pune. She is fellowship in reproductive medicine under Dr. Sachin Kulkarni, diploma in reproductive medicine at IBC Dubai, first rank with distinction, and international faculty for IVF courses at IBC Dubai. I will invite Dr. Saryu to start her talk.
Thank you so much, sir. First of all, I would like to thank ISAR chapter of Haryana for giving this opportunity. And I'm very sorry that Sachin sir is not able to join today. On behalf of him, I'm joining. Obviously, he's the best one to deliver this talk. I'll try my best to whatever knowledge he has shared with me, and we can discuss the topic. So basically, surprises in IVF is our practical topic. Though we counsel prognostic wise once we have a diagnosis, it's very difficult that not all patients we can offer a blanket treatment, and even we individualize the treatment depending on the characteristic of the patient. We may have a different response, and which is not expected in that particular case at all. And this is not very commonly, but in our day-to-day life, we see this often, and actually that disturbs us because that is going to affect the live birth rate, what is we are actually waiting for. So implantation and clinical pregnancy, as we know, is a random chance. Humans, like other mammals, can have pregnancy through the year, but much less fecundity. In lower animals, they will be having only once in a year or twice in a year. But for humans, it is, though the nature has given the fecundity for every month, but the chance is very less. We shall try to explore few modifiable problems in ART response, and then we can avoid poor response in patients. So what is important is diagnosis, then next is prognosis, and next is the treatment. But if the treatment are more effective, then prognosis is less important, because then you are sure that you are going to have a better result. But as the effectivity of the treatment increases, even the diagnosis is not important, because for what indication we have started, if the treatment is so effective, that is not important. Prognosis is a important part of discussion and is the real art of a clinician, because every patient, every couple in front of us is more interested that what outcome we are discussing with them. Prognosis discussion in infertility are time sensitive, and change on the go with new piece of information added. On top of this, the patient expects us to be prophetic role to advocate and predict the success of treatment. And this is we see very often in our practice, that many of the time the first and the last question for every couple consultation is going to be, if at all we are going for IVF, then what is the probability of we having live birth rate? And then we have to explain the prognostic way of getting towards the live birth rate. So we have, when we try to summarize that how we can improve upon the ovarian stimulation result in terms of improving the live birth rate, first comes what about which drugs to be used, whether it is HMG, HP, or if it is RFSH. So we all very well aware about Merit, Megaset, and Engage trial, which talks about HMG, HP versus RFSH injections. And in these particular studies, we have seen that live birth rate is more in HP, HMG when we have a HCG which is derived from the pituitary compared to the RFSH group. And surprisingly, all these studies have used dosage like 225, 150 IU or 150, not beyond 225 IU. Any of these studies have used the gonadotropin dose in the stimulation. And if you see properly the study population or the material methods of all these studies mentions the study has been done for the normal ovarian disease patients, where if you see the exclusion criteria, the exclusion criteria in these particular papers, like somebody is having history of more than 30 follicles of more than 11 millimeter previous cycle, which is cancelled if there is less than 4 follicles, more than 3 RIF, miscarriages, more than 20 AFC, more than 15 FSH, more than 12 LH, significant endocrine problem, overt hypothyroidism, diabetes, thrombocytopenia, autoimmune disorders, endometrioma, and fibroid more than 4 centimeter. So all these are exclusion criteria of these papers. But in a practice, when we think about individualizing the treatment, or maximum chunk of our patients which we are treating are of these categories. But sadly, the papers which has been published about the live birth rate regarding which dose and which injections to be choose is mainly on the good responders and not where we day-to-day commonly see. And this is the fallacy, and that is why if we follow from those guidelines and the dose and duration or which injections to be used, then we can suffer. And these reasons of suffering, apart from the exclusion criteria which we discussed now, it's receptor polymorphism, where there will be either FSH receptor polymorphism or LH receptor polymorphism. And because of that, the FSH dose or gonadotropin dose which we have given, that is inadequate, and the patient will have poor response. We really don't know what is the ovarian blood flow impedance. If the patient has undergone previous any surgery, had endometriosis, we really don't know how much is the blood flow to the ovary and whether that can affect the stimulation effect response. Pharmacokinetics of the drugs is also different, which gonadotropins you are using, which route you are using, subcutaneous, intradermal, intramuscular, and the pharmacokinetics of the drug, how many days it is going to, it can be different, and that will affect the response. Drug diffusion coefficients to the follicle, even that will give an idea, that can also differ the response of the stimulation. But the proof of the pudding is in eating it. So commonly we always try to start our stimulation with adequate dose of gonadotropin. And what consents we actually discuss with the couple, what if we don't get any eggs and we may not get any embryos to transfer? So we must discuss with the client that this can be a scenario and what we are going to do to prevent this situation. So what situation we will come across which can have poor response? Premature luteinization. Poor response if we have poor response, then can we try our best to avoid Poseidon 1? As we all aware that Poseidon 1 is a retrospective diagnosis, and it could be just the inadequate dose, and that's why we are facing Poseidon 1. So poor response in such group, whether can we avoid? Synchronization of the follicle to have more FORT and FOI. If we have low oocyte yield, then what needs to be done next? Embryology surprise is also very common, but we'll leave it to the embryologists to discuss. Premature luteinization, this is one of the most commonly discussed when we talk about poor response in the stimulation. As we all aware that what is the endocrinology, why the antagonist protocol has come into the picture? It is mainly to prevent the LH surge, that is premature luteinization, to have a better yield and to have a better live birth rate. So we know that when once the gonadotropin stimulation is started, first 5 days of the stimulation, the LH is going to fall, and this is because of the factor like gonadotropin surge attenuating factor. So though the follicles are recruited and they are secreting E2, this GNSF is not allowing the positive feedback mechanism to happen and LH to surge. But after these 5 days of after these 5 days of stimulation, the GNSF effect will wear off. And on day 6, when we add ANTA, now this ANTA is suppressing the LH continuously. So imagine if you don't add ANTA, this GNSF effect would have gone, and that will increase the LH. And as we then aware that when more number of follicles are beyond 17 millimeter, will give the trigger. So in antagonist cycle compared to agonist cycle, what is main sufferer is asynchronization. So this was a beautiful paper by Richard Fleming that how like the monitoring of GnRH antagonist protocol, where the recruitment, the nature has already started a recruitment 3 to 4 days prior to the menses, because FSH innate rises 2-3 days prior to the menses. Then we are starting it in early follicular phase gonadotropin stimulation, that is on day 2 or day 3 of the cycle. So already the one wave has started, and then we are starting the second recruitment. So it's a biphasic recruitment, and that is why in antagonist protocol we see a lot of asynchrony, and that could be the reason which can give rise to a low FOT or low FOI. So if we compare with agonist and antagonist protocol, as we know in agonist, when we give lupride, the HPO axis is suppressed. The innate FSH rise is not there, which is otherwise there in our antagonist protocol, where the synchronization is more better in agonist cycle. But in antagonist cycle, there is asynchrony when we are starting the stimulation. Then whether to add fixed ANTA or flexible ANTA, and that also will be responsible for the ovarian response. So in PCOS, even though on day 6 of the stimulation, the follicle size is less than 12 millimeter or less than 10 millimeter, but collectively there are more number of follicles which are going, and that collectively will increase the E2 beyond 400. So even in PCOS, though follicle size is lower, day 6 ANTA start is better. In patients with poor ovarian reserve, the follicle size reaches quite early. And this because we know the follicular phase is shorter in patient with poor ovarian reserve or advanced maternal age, and their FSH rise will start almost 7 days prior to the cycle. So in this patient, even the gonadotropin surge attenuating factor is deficient. So even in these patients, it's better to start fixed day ANTA or rather than waiting for a flexible antagonist protocol. And LH can be triggered by 16 millimeter in poor ovarian response. So fixed ANTA start is day 6. Flexi antagonist start is when the E2 is beyond 400, LH more than 10, and follicle more than 14 millimeter. So when we talk about adding antagonist protocol, so this was the paper in Fertility study in 2003 about the exposure of high LH level and estradiol in early follicular phase in antagonist cycle, which is associated with reduced chance of pregnancy. So LH concentration prior to stimulation and duration of stimulation prior to ANTA start predict the endometrial advancement, and it is more in patients for fresh embryo transfer. So if you see, in this particular slide, when the number of follicles are more than 15 millimeter on day 6 of the stimulation, the ongoing implantation rate and ongoing pregnancy rate is better in fixed group rather than flexible group. The next, the below graph is actually describing about the LH level and the stimulation day with fixed antagonist protocol and flexible antagonist protocol. So the dotted line is about flexible and the fixed is ANTA. So if you see on the left graph, the LH with ANTA added is continuously on the lower side, while it is in the flexi ANTA on day around 8 of the stimulation, it is surging. In estradiol level, also it is the same, that if you add fixed antagonist protocol, initial after day 6 to day 8, it is on the lower end, and then it will start rising as the follicle are growing and they're having more granule proliferation. But in flexible antagonist protocol, it will be on rise. So in this particular study, they found a group where fixed and flexible antagonist protocol are having similar response if the follicle is more than 50 meter on day 6 of the stimulation. And in this particular way, like when they calculate the LH and estradiol, when the follicle is more than 50 millimeter, the flexible ANTA and fixed ANTA have similar result in terms of E2 and LH value. So important is 50.5% of women lacked a follicle more than 15 on day 6 in the complete study group. And flexi group, no follicle, number of follicle more than 50 meter on day 6 had least ongoing pregnancy rate. So again, it tells that fixed antagonist protocol is better. If certain threshold of estradiol is exceeded, progesterone receptors on the endometrium are induced. This threshold is probably reached earlier in anti-cycle, especially if we are starting antagonists delayed. And that is one more reason that why we should add fixed antagonist. So this can be another rare scenario where which we can come across. Though we are adding antagonists, still there can be a LH escape. This was published in Fertility Sterility. We talked about diminished ovarian reserve in antagonist protocol, where there is breakthrough luteinizing hormone surge, even they have added anta. So 10,809 cycles were studied, and breakthrough LH high was 0.3 was observed in 0.34% of the cases. And age was beyond 40 years, poor ovarian reserve, high day 3 FSH, low AMH, and by day 11 the breakthrough was noted. So the theory proposed here that with antagonists added on fixed day, there is fast decline in the LH. Now just imagine that increase because the follicles are continuously recruiting and more amount of E2 is going to be generated, though we are added antagonists. There is increased pituitary responsiveness by blocking desensitization of this endogenous GnRH. Thus, the pituitary is now more hyper-responsive for this LH release. So sometimes this balance between increased pituitary sensitivity and maintenance of competitive blocking of the effect of antagonists is not there. And that is why, though we have added antagonists, because the continuous rise of estrogen that is increasing the LH, because pituitary is now too much hypersensitive for this LH release. And that is why these patients may have LH escape. And that we can see if we are doing alternate day or 48 hours LH levels. Now, whether the timing and duration of GnRH antagonist downregulation for IVF cycle will have impact on oocyte quality. So in this particular study, they are given pre-treatment with COC pills, then HMG stimulation and flexible anta was added. But CRP was same across any given antagonist duration. So this mainly it conveys that antagonist duration and days is not going to affect the outcome. If LH is high on day 7 to 12 of the stimulation, it is just snapshot reading. And that is very important, having a LH continuous activity throughout the stimulation. Because if the LH of 10 to 40 MIU, we have a better yield in this particular cycle. If no associated rise in progesterone, then there is no difference in clinical pregnancy rate or live birth rate. So if your LH is only rising, but there is no associated rise in progesterone, it is not going to affect your clinical pregnancy rate or live birth rates, and it's more over in fresh embryo transfer. Higher LH is required to luteinize the larger follicles. So this was a nice study published in 2023 that premature LH surge without elevated progesterone is not having any adverse effect on cumulative live birth rate. And in this particular study, when there was LH surge, but there is no rise in the progesterone, in both the groups, they observed that cumulative pregnancy rate and live birth rate were the same. Poor response on day 6, when there was less than 4 follicles, could be expected or unexpected. Then LH more than 10, but E2 is less than 200 and follicles less than 10 millimeter. Then definitely this patient is not stimulated or there is no recruitment. So that is poor response. Then we have to review the counseling, and then we have a question whether we have to step up the dose. But now if we add the dose, then anticipate prolonged stimulation, repeat test, or increase the cost. And now you are adding at that particular time. So there can be more asynchrony and your FORT and FOI is going to be affected. Unexpected poor response, the common reason is what we see is group 1 and group 2 of Poseidon, where there is a good ovarian reserve markers, but we get less than 4 oocyte. The reason could be receptor polymorphism, obesity with cardiometabolic issue. When we have started the gonadotropin like IVF stimulation with low dose, or we have not given the trigger in a proper way. Changes in next cycle, then we have to think of better drug, like like Gonalef, or recommend FSH or HMG-HP combination. Increase initial dose of stimulation. add LH in stimulation, and counseling for the dual stimulation. So this is very important for counseling, that what if we have suffering, because Poseidon 1 and 2 is always a retrospective diagnosis. Our next challenge is what we are going to do in the next cycle to improve upon the response. So main thing is start with adequate dose, because the first thrust of the FSH is very important. And throughout LH activity, so only RFSH, instead of only RFSH, if we have LH in stimulation, that will have a better effect. And then if there is low reserve in that patient, we have to counsel that we may require more cycles. 1 or 2 Poseidon groups, less suicide in spot of good ovarian reserve. So reasons could be FSH action interference due to low or high molecular weight proteins, antibodies against granular cells, receptor polymorphism. There could be defective angiogenesis and low diffusion of exogenous gonadotropin. So whether to go low on the dose for poor responders. This is a very nice paper by Polizos, Say No to Mild Stimulation, which was published in 2020. So aging leads to decrease in primordial follicles and increase oocyte chromosome problems. So in practice, Poseidon stratified low prognosis patient into unexpected low response and expected poor response. So one may think that if the the substrate is low, then why to go on the higher dose? And then this particular study mentions that why say no to the mild stimulation? Because in this particular study, they observed that inadequate follicle response was there. It was when the gonadotropin stimulation dose was 150 IU, 30% had inadequate response. When it was 225, 8% had inadequate response. And when it was 450 IU, only 4.4% have inadequate response. So as the gonadotropin stimulation dose was on the higher side, the response was better. And individualization of doses will decrease cycle cancellation and increase number of ET. Higher number of cycles means more financial burden. And we all aware about the Optimist trial. There are many cycle cancellations when they started with lower dose. And for the 56% of the patient, they have to increase the dose on the go of stimulation. So that is why it's better to go for adequate and more dose. One of the reasons could be FSH receptor polymorphism. So this was paper published by Polizos about receptor polymorphism and how it will affect the ovarian response. And they have done study on 6165 and 6166 and another one that is 1394205 receptor, which are very commonly seen in ethnic population. And this prevalence of hypo response was according to the genotype. But if we go higher on the dose, then no difference is observed in this receptor polymorphism group. IVF for PCOS, poor response has become more problem than OHSS, because everybody was in fear of preventing OHSS, and that's why I started with low dose. But because the FSS threshold was not overcome with that inadequate dose, we many of the time we may have poor response in PCOS. And what was the theory behind it? Look carefully about this slide. If you have a normal ovarian reserve patient with normal menstrual cycle, at 5 millimeter, the follicle will be having only FSH receptor and cyclic AMP expression will be low. As the follicle has recruited and gone beyond 10 millimeter, now the FSH and LH receptor will be similar and they will be on this receptor. After that, after 10 millimeter, the follicle is now responsive to the LH release. So cyclic AMP differentiation from this LH will be after 10 millimeter until pre-ovulatory. But what happens in anovulatory PCOS, this 5 millimeter only is having FSH, LH and insulin receptor. So even between 5 to 8 millimeter, there is a acquisition of LH receptor and increase in the cyclic AMP is there. Because cyclic AMP increase is there when the follicle is at 8 millimeter, instead of going to the pre-ovulatory phase, there will be a terminal differentiation. And because of that, we see many of these atretic follicle and they are not able to grow beyond 8 millimeters. So basically, the FSH and LH receptor is occupied by the follicle in PCOS quite early compared to a normal ovarian reserve patients. And that is why increase in the cyclic AMP in anovulatory PCOS will make that follicle atretic and there will be a terminal differentiation. So in normal follicle development, once the granular cells respond to LH, that is at 9.5 to 10 millimeter, they undergo only 2 cell divisions to reach pre-ovulatory size. But in anovulatory PCOS, granular cells are responsible to LH at 4 millimeter size. So if cells can undergo 2 more division, it reaches only 8 to 10 millimeter, and the increase in the cyclic MP happens, and the follicles got arrested, and there will be terminal differentiation. Then whether the phenotypes affect the ovarian response, and this was paper in RBMO online in 2018, whether the cumulative live birth rate in patients with phenotype. So issues with PCOS stimulation, the risk of OHS is there. So when they gave narrow dose, to avoid OHSs, they gave lower dose in patients with PCOS phenotype, and low dose protocols with fear of OHSs, HC trigger, and fresh plus or minus frozen embryo transfer was particularly observed in this particular study. And they observed the CLBR across the PCOS phenotype. So if you see, PCO morphology and phenotype D were having better response, because we know they are mild PCOS or like good PCOS in terms of response. But phenotype A and C were having hyperandrogenemia, and they suffered with lower cumulative live birth rate. So this was a story in 2018, but recently in 2022, this was a paper published by McLean et al., which talks about throughout the PCOS phenotype, if you give adequate or full throttle dose of gonadotropin stimulation, then you are overriding the PCOS endocrinology. So go full dose, even PCOS is having any of the phenotype, and that you can avoid poor response in this patient. So if you see in this particular paper, if they have given the dosage according to they are given the higher gonadotropin doses across the cycle, and if you see total number of oocyte retrieved, fertilization rate, none of that is affected with the phenotype. And that's why to override the PCOS phenotype, just go for the full dose. You are actually overriding the endocrinology of the PCOS. Then RFSH alone in the stimulation of PCOS is definitely a problem. If you give COC pre-treatment, then LH drops. So if you give COC pre-treatment for a longer time, as soon as you start the COC pill, the FSH recovers within 48 hours, but LH may take longer time. Now you are waiting for the menses. So 2-3 days later or 5 days later, the menses start, and then you are starting the stimulation with RFSH. Initially, the gonadotropin suggestive factor will play a role. The LH will be still low. Then you are adding antagonists. So LH with LH again low. So throughout the cycle with COC treatment, your LH is completely on the lower side. Then you are giving agonist trigger with the fear of OHSS. And now you are facing empty follicular partial or complete empty follicular response. And that is how we suffer in PCOS if we give any pre-treatment. That is why in ASHRAE guidelines also it is mentioned, no pre-treatment is advisable. You can directly go ahead with the stimulation, because starting with low LH pool, then again 5 days of GNSF action, and then again adding ANTA will maintain LH throughout the stimulation on very lower side. Then one of the factor is in patient when we are giving agonist trigger, we should be aware that there could be 5 to 7% failure of agonist trigger. So measuring of agonist trigger is very important to avoid empty follicular syndrome or low FOI. And as we know the physiology that in 4 hours the LH goes up and in next 20 hours it goes down, but the progesterone keeps rising. So we measure the trigger after 12 hours of giving agonist trigger. And 12 hours post trigger, if the low LH is there and high progesterone is there, where we have seen in this particular slide, then we know that trigger has worked. But the progesterone is less than 5, that definitely tells us that trigger has not worked, and then we may have to think about giving AC to this patient. So if we give only agonist trigger and it does not work, low meta phase 2 sites, less than 50% if we are seeing, then think of double trigger. So at 40 hours, give agonist trigger, and 34 hours, give HCG trigger. The important thing here to know is that it can be it can cause premature ovulation, and that everybody can fear with double trigger. So ibuprofen of 400 milligram thrice a day, post trigger till OPU, will prevent premature rupture with the physiological action of ibuprofen, that it will a prostaglandin synthetase inhibitor. Now, antifollicular syndrome following generalized trigger in PCOS undergoing IVF cycle. There could be a genuine empty follicle syndrome or pseudo empty follicular syndrome. So genuine empty follicular syndrome could be because of dysfunctional follicogenesis, faulty granular cells, defective oocyte maturation, follicles need longer duration of LH exposure, DOR patients, where there could be gene mutation of LH and HCG, or in patients with advanced maternal age. So this could be the reason of genuine empty follicle syndrome. But what we face more is pseudo empty follicle syndrome. If the post-agonist trigger, your LH is less than 15 or progesterone is more than 3.5 nanogram, then we may predict that empty follicular syndrome. And in this patient, then we can think of again giving HCG trigger. Now, what if in first cycle, the patient is having 0 oocytes? So this was study done in Israel. Only Israel can do the study because any number of IVF cycle is free of cost over there. So this was published in 2021, where since beginning of the one cycle, these are the number of cycles, 1 to 9. So if you see, they have increased the FSH dose in subsequent cycle. And then they have observed that high dose of FSH in subsequent cycle have improved upon the number of oocyte retrieved. And like, the cumulative right birth rate per OPU was like better till the time of 5 IVF cycle. But as they go on beyond 5 IVF cycle, even though increasing of dose has not done much difference. So increasing of the dose is one of the treatment, but more than 5 cycles of even increasing the dose, it is not going to make much difference in terms of cumulative live birth rate. So what if like you have suffered with the poor response, and what is the risk of response during the repeat IVF cycle? This is the most common discussion with the couple after their first IVF cycle. Low AMH, low oocyte yield, and then time interval between cycles were independent markers of suboptimal response. So first two is okay, like, low AMH, we know that is going to be a suboptimal response. But what should be the time interval between your first cycle, which had poor response, and your next cycle in terms of having response in the next repeat cycle? So they have identified the risk factor from initial IVF. If the risk factor from the first IVF where you had poor response was poor ovarian reserve with low ovarian reserve, the risk of poor ovarian reserve in repeat IVF, if they have done it within 1 year, it is 57%. But if it is more than 1 year, it is 73%. So they have taken into consideration the previous response with normal ovarian reserve within 1 year, 28% only low risk of POR. But more than 1 year, it is 43%. So all these risk factors, they're actually pointing out, if at all you want to go for the next cycle, do it within 1 year. And if you are postponing it beyond 1 year, the results in terms of risk of again facing poor ovarian reserve is more. And that's why you should not take too much time between 2 cycles. Then synchronization. This is also one of the reasons why somebody may face a low output. As we know that FSH will start before menses, and this natural innate rise of FSH will have one recruitment. And when we are doing antagonist cycle, we start on day 2 or the day 3. So we are actually starting our cycle with asynchrony that can lead to a low fold. So if you want to have a better response, synchronize where the innate FSH rise is going to be there. So how we can synchronize? That before 3-4 days prior to the cycle, give estradiol. That estradiol will prevent the innate FSH rise. And then on day 2 or day 3, you can start with the gonadotropin stimulation with good response. Or synchronize again when there is a pre-ovulatory phase where you can just give agonist trigger and immediately you can start with the next response. So asynchrony will continue even if you are giving any pre-treatment. So for example, if you are giving OC pills, it will keep the FSH and LH low. But then you are waiting for the menses to occur. FSH is going to rise within 48 hours of stopping the OC pills. And then when you are waiting till the menses, again there is innate FSH rise. But LH may not rise in subgroup of 5 days. So you have starting with low LH pool, but again with asynchrony because FSH already started recovering. So 5 days washout period after OC pills won't give you a synchrony. And in those cases, then how we can go ahead with the synchronization? So if a lady is having anovulatory cycle, give progesterone for 10 days. And then after progesterone of 10 days, immediately start estradiol 4 milligrams till day 1 of the stimulation. So you are waiting for her menses also, but before that you have started estradiol. So you're not allowing the innate FSH to rise and you have a synchrony, and then you start your standard antagonist cycle. If a lady is having ovulatory cycle, as I mentioned just now, that estradiol starting 3 days prior to the menses, and then wait for the menses. Once the menses start, then 1 day washout period of estradiol, and then you start antagonist cycle. You will face less asynchrony and better with yield. Generalized stop agonist cycle, this could be one of the cycle, but it is not patient compliant most of the time. So in this generalized stop cycle, we are doing generalized specific hypophyseectomy, where we are giving Leuprolide 0.5 ml from day 21 of the cycle till the time of the lady gets menses. Once the lady gets menses, then you stop this Leuprolide 0.5 ml and start with gonadotropin, because at this particular time, because you have started it 7 days prior to the menses, now there is a synchrony, and then you are starting with gonadotropins, and then you follow antagonist protocol. The only fear here is that there could be a suppression of axis, and if by the menses, if the LH is not recover, you have to check whether you are starting with good LH pool. So increase the HMG doses. And one of the biggest advantage of this, it is a combination of agonist and antagonist cycle. You have a flexibility of giving either agonist or agonist or HCG trigger. So this was a protocol, this was a delayed start protocol, which is discussed in this particular paper with generalized antagonists, which improves the outcome in poor responders. So conventional protocol, give estradiol, then give gonadotropin and go with antagonist cycle to have synchronization. In this delayed start, they have done E2 priming, then they have added generalized antagonists. So they have completely suppressed the HPA axis, and now they have started with the gonadotropin protocol, gonadotropin stimulation. So pre-treatment to synchronizing the follicular cohort in normal responder doesn't make any difference. In PCOS, more to decrease LH, OC pills or antagonists, use HMG stimulation. There is, in either of the group, there will be the same live birth rate. Diminish ovarian reserve, every egg is important, so synchrony will be more effective. AMH less than 0.5, grade 4 Poseidon, group 4 of Poseidon, COC antagonist or generalized stop agonist protocol suppress more, and then you have to think about luteal stimulation or duo stimulation to have better response. If AMH is more than 1.2, Poseidon group 2, unexpected poor response, they may benefit provided the receptor polymorphism is not responsible for hyporesponse. They suffered this in their earlier cycle. So start with good gonadotropin stimulation with adequate dose to face the poor response at the end of IVF stimulation. Thank you so much for your patience hearing.
Thank you, Dr. Saryu. It was a very nice, eye-opening lecture. And you actually you mentioned all twist and turn in an IVF cycle, what surprises, what twist and turn we get in a cycle. So thank you so much on a last minute call into giving the lecture. Thanks a lot. And it was a nice lecture, mention all ABCD to Z.
Thank you so much. Thank you.
Thanks a lot. Okay, now I invite
Saryu, how many times can I ask one question from Dr. Saryu?
Yes,
when do you do LH in your stimulations, whichever cycle? What days do you repeat LH? And what are the hormonal tests that you do in your stimulation cycle? Maybe day 1, day 2, what do you do? Then in between, what do you do? When do you do serum progesterone? When you do LH? Just for everybody's knowledge.
Yeah, so nowadays, all of us had moved toward the freeze-all cycles. So to be honest, the too much of monitoring of this hormone during the cycle is not mandatory. But there are patients where when we have to answer the patient that why you have inadequate response, then this hormonal monitoring is going to be more important. As for example, let's say we want to go for fresh embryo transfer, on the starting of day of the stimulation, progesterone should be less than 1. Then your LH should be more than 2. And estradiol should be less than 80. Then in that case, the ovary is quiet and it is down regulated, and it's better to start with the gonadotropin antagonist protocol. Then on day 6 of the stimulation, if it is a fixed antagonist protocol, you need not start. But sometimes you may suffer with poor ovarian response and there is no recruitment on day 6 of the cycle. That time we will do the estradiol and LH level. If estradiol is less than 200, and even the LH is on the lower side, means she has not stimulated, there is no recruitment at all, then you have to counsel the patient whether you have to go for cancellation of the cycle, or now you have to starting this as a day 1 of the stimulation, which is going to increase the cost, and we really don't know how the next stimulation is going to be. Then when on the day of trigger, definitely LH and progesterone is important if you have a PCOS or high responder and you are going to plan agonist trigger to measure the trigger 12 hours later, where you are expecting the LH to rise and progesterone to rise after 12 hours of giving agonist trigger. Estradiol, it is not mandatory, but for academic reason, we do on the day of trigger to see how many follicles we are going to have out at the end of retrieval. And as long as you are practicing freeze-all policy, progesterone is not mandatory, but you are planning to have a fresh embryo transfer on the day of trigger, then you will measure the progesterone value. When it is less than 1.2, you can plan with the fresh embryo transfer. So this is how the we think about monitoring. In case of stop agonist protocol, as I mentioned, if at all we are planning in separation, then before starting the gonadotropin, we always do LH value, and cross check it is not less than 2. Your pre-treatment is not suppress the LH value more, and then you start with the stimulation. If the LH is very low, then we give estradiol of 3 to 4 days and see the LH again, because this estradiol is not allowing the FSH like innate rise, but it is more LH pool is created, and then you are starting with the stimulation with good LH pool, that will be having a good result. So nowadays pre-treatment we do is only with estradiol. So monitoring is mainly if at all we face some inadequate response, then to counsel the patient that this is all the hormonal things we have looked upon. But otherwise, if for freeze-all policy, it's not mandatory to do all the hormonal tests.
And pre-treatment with estradiol is a twice a day, 4 milligram twice a day, or a thrice a day, 4 milligram or 6 milligram?
Ma'am, if we start from 7 days before the cycle, 2 milligram twice a day is more than enough.
Okay.
And thank you, Dr. Saryu, for such a detailed talk and so many twists and turns. Just
Thank you.
asking, till how late you can start this stimulation? Like you said, first you give estrogen, then you will give cetrorelix, and then you will start the gonadotropins. In those cycles, till how
Yeah.
late you can start the stimulation?
So this was only a novel protocol which has been discussed in poor responders, sir. This we are not doing as a routine. For let's say for other normal responder patient, we just start estradiol 4 to 5 days prior to the cycle to avoid the innate FSH rise. But the delayed start of antagonist protocol, what I was discussing, is only a recent studies which is mentioning about poor response and what you can do to improve upon the more number of oocyte in this particular patient. So they are given estradiol and then antagonist for 5 to 6 days. So that is why like it is a combination, like it will act like a agonist protocol, and though we have actually given estradiol, so that is going to increase the LH. You are giving antagonist as a pre-treatment, and then you are starting with the gonadotropin stimulation. This I just mentioned because I just came across this paper, but to be honest, we just start E2 pre-treatment, and once she gets the menses, 1 day washout period, and see the synchrony and start with the gonadotropin antagonist protocol as we are doing as a conventional protocol.
Thank you.
Thank you, sir.
So, okay, now next we move on to the next lecture. And for that, I would like to invite our chairperson. So, Deepika, please display the slides of chairperson. Okay, our first chairperson is Dr. Prabjot Kaur. Dr. Prabjot Kaur is founder of Karnal Obs and Gynae Society, and she is the scientific director of Divine India IVF Institute of Women Reproduction, senior consultant and head of the department Obs and Gynae, Guru Nanak Hospital, Karnal. And madam, now the next is Dr. Isha Khanuja. She is the director and head of the Lokpriya South End Fertility and IVF, Lokpriya Hospital, Meerut. So our next is dear Dr. Manisha Mehta. She is Director Apex IVF Center Sirsa, past Secretary Haryana ISAR. So Dr. Lakshmi Goel, IVF Consultant, Cloud9 Fertility Center, and Fellowship Reproductive Medicine Aspire, and she is our treasurer in ISAR Haryana. So now I would like to request Dr. Prabjot to introduce Dr. Jyoti, Dr. Pooja Dheer Bhayana. Okay, one more, sorry, my bad. So Dr. Pooja Dheer Bhayana, she is fellowship in fertility and ART Ahmedabad, and now she is a consultant in Sonakshi IVF Hisar and past consultant in Nova IUI Hisar. So
I think I'm already introduced. I'm already introduced. Thank you so much, Dr. Manju. I think we'll start with the talk and we'll ask the chairpersons to give their expert comments at the end of my talk. So I'll just share my screen and can you, yeah, so I will just do that.
Oh, nice of you, Dr. Jyoti. Thank you.
Thank you so much. Thank you. So we come on to the embryo transfer techniques. And once we've done a nice stimulation, Dr. Saryu has told us how to do it, what dose to use, which protocol to use, how to do priming, how to make a good cohort, and then we are ready with good embryos. And if we are not doing our embryo transfer properly, the whole show, the whole mehnat, the whole whatever we have done goes waste. So itna sab jo patient ko stimulate kiya, the amount of money, the hope, everybody, everything gets shattered if we do not do a good embryo transfer. Because embryo transfer is the final and the most crucial step in the IVF cycle, and in which the aim is to atraumatically and accurately place the embryos within the uterus so that there's a proper implantation and development, and an efficient and effective embryo transfer can positively impact the success rate of IVF. So what are the preparations and requirements that we do before embryo transfer? We should have a written informed consent before the procedure, should take a proper history before the procedure, because we might sometimes in our OPD, we might have missed something and we don't remember. And then when we go for embryo transfer, and the patient is on the table and we say we see a polyp there, or we then take a history and we anticipate that this is going to be a difficult embryo transfer. So it is always a good idea to have a good proper history and to do a basic ultrasound scan, because sometimes the patient in the frozen comes after months. We have done her ultrasound long time back and we've forgotten what exactly how the uterus was, whether it was acutely anteverted or acutely retroverted, or was there any other history or any surgery on the cervix, or how whether we expect any difficulty there, or is it going to be a easy transfer. So the ET room always is close to the lab. The temperature has to be very comfortable, and we should have all the sizes of the speculum. Sometimes we need a longer speculum and then we run and go and get it. So we should have everything ready on our trolley. And if we are anticipating a difficult transfer, then we should also have our instruments for the manipulation. Has to be done completely aseptically. The information that we need to fill it in at the time of transfer is the date and time of the embryo transfer in our form, the person who is loading the catheter, the person who is performing the transfer, how many embryos, that is the number, the stage, the quality of embryo, everything needs to be documented on our chart. The type of catheter, whether it is a soft catheter, rigid catheter, maybe also the company make, we can, if we have suddenly started using a new catheter and our rates are falling, so we can anticipate. So small little things, small little mention on the form can sometimes help us go back and do the audit and think about our mistakes that we might, or the changes that we have done in our procedures. Recommendation: the bladder should be full enough so that patient feels the urge to urinate. One does a speculum examination just prior to ET. So this is because this is the final opportunity to rule out vaginal or cervical infections, remove cervical mucus with a cotton swab, or maybe use a syringe, and cleans the vagina or the cervix using sterile water or saline prior to doing a ET to minimize the bacterial contamination. So these are the recommendations. Always we are doing the ultrasound, abdominal ultrasound guided embryo transfers, where the patient is asked to fill up the bladder, vagina is irrigated with saline, transabdominal probe is placed on the suprapubic region, catheter is introduced, the embryo catheter, and the movement of the catheter is monitored in ultrasonography as it traverses the cervical canal, the internal os, and then enters the uterine cavity. So it needs to be done very, very gently. And we can use coaxial catheter systems with eco-dense tip, which the tip facilitates the early detection of transfer, and the catheter movement. When we move the catheter under ultrasound transducer, one can see the gentle movement which should be done in the transverse plane without to and fro movements. And the catheter tip needs to be placed at upper middle third of the cavity, which has the maximum implantation potential. So after deposition, what are the do's, what are the don'ts? After gentle deposition, the catheter is left in place for a few seconds and then withdrawn gently. So this we used to do, but the guidelines these days now say that there's no need to wait. You can just put the embryos and come out. So there's no need of waiting there. Maybe normally, previously it was, we used to wait for a few seconds. Now, the catheter, it is checked for any retained embryos, and if we find any retained embryos, everybody waits there, the whole team waits, and we just we transfer them immediately. Now, the air bubbles which are used to bracket the embryo containing media give an accurate visualization of the final site of the embryos in the uterine cavity after the transfer catheter is removed. So once you see such echogenic bubbles, these are those bubbles which have been put by the embryologist while we are loading the catheter. We are taking the air bubble, then the media, then the air bubble, then the media with the embryos, then again the air bubble and some media. So we are locking those embryos, and they can be seen under ultrasound guidance. Don't touch the fundus while doing the transfer, because you are initiating uterine contractions and it can lead on to expulsion of the embryo. So the patient here, this is the short clip where the embryologist checks, confirms the patient. The lab, there are always two people who are doing it. This is the tray. There is Cusco, sponge holder, bowl, cotton balls, the drape cut sheet. One cleans the cervix and vagina with the cotton ball, or you can use a cotton swab stick to gently remove the mucus from the cervical canal. And then you place the guard on the outer catheter according to the length, the uterocervical length, and then you introduce gently the outer catheter through the canal and go beyond internal os. So you can always get that feel also when that snapping, once you just cross the internal os, even by that tactile feel you can see, and you are checking it under ultrasound. Here you are asking the embryologist to load the catheter. Once they have checked the name, identity, the catheter is being loaded by the sandwich technique. And these markings serve as the advancement, how much we have to advance the inner catheter. And then with the gradual, once the catheter is now removed, and again the embryologist checks for any retained embryos, if any, and we just, this is the final the final counseling, that how it went and everything, that is being explained at the end of the procedure. So the transvaginal ultrasound guided embryo transfer, normally most of us do a transabdominal ultrasound guided transfers, but transvaginal ultrasound guided transfers can also be performed. And here what we do is, one does put in the embryo transfer catheter is introduced through the canal, followed by the introduction of the transvaginal probe. And then the further advancement of the embryo transfer catheter is monitored by the transvaginal ultrasound. The advantage is that the patient does not need to fill the bladder. It is more patient friendly and be conducted without the assistance of the sonographer. So TVS guided transfer is a little more comfortable in comparison to transabdominal, because the patient does not need to fill up the bladder, and the patient becomes very inconvenient so many times when we have made the bladder overfull. So the fertile sterile into 17 compared transabdominal versus transvaginal, and there was no difference between the groups regarding clinical pregnancy, ongoing or carriages and birth rates in whatever technique, whether you use a transvaginal. Now, clinical touch embryo transfer. So some clinicians, most of us gynecists, are excellent in handling the uterus and understanding the axis and also doing so many sounding of the uterus that now we know that, okay, we've just crossed that internal arch by that tactile sensation, and by the clinical touch also many people have been doing embryo transfers and they have got excellent results. And they feel that ultrasonography does not provide them any extra advantage. And there were 17 randomized trials which compared ultrasonography guidance with clinical touch for the embryo transfer. And there were a good number of around 1,200 patients in each group. And but they demonstrated that significantly there's higher incidence of pregnancy with ultrasonography guidance, but there was no evidence of significant difference of the birth rate between the two. There are evidences in favor of the ultrasound guided transfers, and many trials, a trial involving roughly 8,400 ET cycles, which was compared, and in this, the pregnancy was 17 to 32% better with sono guidance than without. And different transfers were lower in the sono guided group as compared to the tactile or group. So it was 9% with the ultrasound guided versus 15% with the trials, and 4 cohorts. They suggested that transabdominal always was better. It improved the implantation and the pregnancy rate. Also suggests 3D versus ultrasound. Is there any difference whether you use a 3D? No, there's no difference between the clinical pregnancy or any of the secondary outcomes, whether you use a 2D ultrasound or a 3D ultrasound. Selective sonography is always recommended where difficult embryo transfer is anticipated, because here you can understand the axis, whether how the uterocervical axis and the angle that we need to sort of maneuver our hand while we are doing these transfers. So in this, the comparison of the birth and ongoing pregnancy rates, this was the ASRM embryo transfer guidelines 2017, which favored ultrasound guided embryo transfer. Now, the ET techniques, the use of ultrasound versus clinical, again, significant increase in clinical, ongoing, and live birth with the use of ultrasound. The bladder fullness, ET on a full versus empty bladder, there's no difference across both the groups. Double-step catheterization is more reassuring than single-step catheterization to accomplish the transfer. And you can load the catheter anyhow. You can just use a medium with the embryo with the air on both sides, or you can use medium air, medium with embryo, air, or medium, or you can just take medium with embryo and no air. But there is insufficient evidence to suggest the superiority of air fluid or fluid-only methods during embryo loading. Small volume should be used. This is highly, highly recommended, because if you use larger volume, there is going to be, these embryos are going to either go into your tubes or they may flush out back through the cervix. So a volume of the medium should be between 10 to 30 microliters only. Sometimes we just rely on the placement of the air bubble, but it is not always where we have placed is the right position that we can assess by that air bubble, because it depends on various other factors like the pressure during embryo transfer. If you're using a lot of pressure, that air bubble will go more higher up. or if the positioning of the catheter tip, if your catheter is a little rotated inside the cavity, or the shape of the cavity, or the rotation of the uterine body, and all these make a difference. Pressure on the cervix, whether we have a mechanical effect by unscrewing the speculum so as to apply gentle pressure on the cervix. Should we leave it like that, the speculum with the pressure on the cervix? It showed no significant effect for clinical pregnancy or ongoing pregnancies. Pump regulated use pump regulated transfer to manual transfer that should difference. Does removing mucus from the canal improve the pregnancy and live birth? There is fair evidence based on a RCT and another cohort study that there is a benefit to removing the cervical mucus at the time of embryo transfer. And these are from the ASRM 2017 guidelines. Soft versus firm catheter. So soft, always a soft catheter is better. 27 RCTs comparing the outcome between the soft and the hard catheters, and there was a significant increase in the pregnancy with the use of soft catheter, but no difference found in the ongoing or the live birth rates. So the use of echogenic versus standard ET did not affect the rate of clinical pregnancy. 3 RCTs compared to that are a similar pregnancy rate, and small RCT compared the outcome of transmyometrial to transcervical ultrasound guided. In some cases where you cannot negotiate cervix, and the only thing that you can do is you can go transmyometrial, very difficult cases, and whether if you're doing that, there is no difference in the rate of clinical pregnancies. Nurse versus doctor. If a nurse is doing it versus a doctor who is performing it, there were 2 RCTs comparing this, and it showed no difference between the 2 groups, whoever performs it. But one should be very, very efficient, whether even if it is a good nurse doing it, it is as good. Does positioning the catheter at time of transfer affect the implantation? There's evidence based on 7 studies, 3 RCTs, 4 cohort, that placement of the catheter tip in upper or middle central area of the cavity greater than 1 centimeter from the fundus for embryo expulsion optimizes the pregnancy rates. Does the time interval before withdrawing affect the embryo transfers? There's evidence based on 1 RCT to recommend that immediate withdrawal of catheter after embryo expulsion. The presence of mucus, evidence based on 7 cohorts, not associated with that presence of mucus on the catheter. Once we withdrawn it and you find a mucus or a blood on the outer catheter tip, once withdrawn, it is not associated with the lower clinical pregnancy or live birth rate. And the rate of injection of catheter load. So there is insufficient evidence to recommend any specific injection speed of the catheter at the time of transfer. The retained embryos, if we have retained embryos and if we have to retransfer them, does it affect it does not affect the implantations. Bed rest. Now, there is good evidence not to recommend rest after embryo transfer. The fair evidence is that acupuncture or antibiotics or powder gloves, there's no difference, and they don't have any adverse effect, and there's no removing mucus at the time of transfer. This is a fair evidence. Insufficient evidence to recommend for or against analgesics to improve the transfer outcomes. There's insufficient evidence if you are using, whether to recommend or to not use analgesics. Again, there's insufficient evidence regarding anesthesia during transfer. There's no clear benefit about it, and there are inherent risks associated with anesthesia. Therefore, routine use is not recommended. Also, massage therapy to improve the transfers is not recommended. Again, the use of whole systems like traditional Chinese medicine to improve the transfer outcomes. There's insufficient evidence, again, regarding the positioning of the catheter at time of transfer, insufficient evidence, and also the injection speed of the catheter. Pharmacological interventions. Now, sure, atoxibin is one thing which promotes the uterine relaxation, and use of atoxibin before the transfer gives a good ongoing pregnancy rate was shown to be increased. Nifedipine, no improvement. NSAIDs, no improvement. Steroids, also no effect. HCG supplementation, also no effect, but there's increase in the biochemical pregnancy rates. Hyaluronic acid was seen to increase the birth rate, but did not affect the ongoing pregnancy rates. GCSF also showed a significant increase in a meta-analysis of 4 RCTs evaluating the effect of using GCSF at time of ET compared to placebo, showed a significant increase in the pregnancies, and plasma infusion 2-fold increase compared to placebo, 17-hydroxyprogesterone, no significant effect. So this was from the human reproduction update from the comprehensive systematic review and meta-analysis on the interventions to optimize embryo transfer in women undergoing assisted reproduction, published in 2022, that among these interventions, the ongoing pregnancy with atoxibin, hyaluronic acid, and the GCSF, and the plasma infusion. These 3-4 things they have said that they can help us. So the supported by literature, the interventions, abdominal ultrasound, the removal of cervical mucus, use of soft catheters, placement of catheter tip in the middle area, greater than 1 centimeter from the fundus, and immediate ambulation once the transfer procedure is completed. So these are the literature supports these interventions, and those that are not beneficial are acupuncture, analgesics, massage, general anesthesia, Chinese medicines, prophylactic antibiotics, and waiting after expulsion of embryos for any specific period of time before withdrawing the embryo transfer catheter. So these are, this is, I think, in brief that I would like to state about the embryo transfer techniques. And I think these are something most of us know about it, but I think maybe it might have helped some of us. Thank you so much. Over to the chairpersons.
Okay. Anyone want to ask question? So anyway, it's a very nice and crisp and very elaborative simultaneously, Dr. Jyoti. It's a very good lecture, and especially the video that the clip you explained from the start to end. It's very nice, self-explanatory. No need to ask anything. Okay, so anyone want to ask any question?
Hello.
Hanji, Dr. Pooja.
Hanji, ma'am.
Hanji.
I would like to thank Dr. Jyoti for such an elaborative lecture. One thing I was confused in the line was use of hyaluronic acid. It increases the live birth rate, but ongoing pregnancy rate is not affected. I think I'm not able to understand this line.
Okay, so I also must have not read it so very properly, but definitely it there must be some, if it is improving the live birth rate, it is going to definitely increase the clinical pregnancy rate
Pregnancy rate also.
So,
Yeah.
Dr. Pooja, the hyaluronic acid is only give you implantation. That is the attachment part. And implantation can be a normal embryo, can be an abnormal embryo. That is
Yes,
the only reason hyaluronic acid give you more multiple pregnancy rather than singleton pregnancy. But if an abnormal embryo attached, that doesn't guarantee you for a live birth rate. Okay,
Right.
can give you, that cannot guarantee you ongoing pregnancy. That can give you only the implantation.
But then the sentence is it increases the live birth rate. It
Maybe
increases the
there
live
was
birth rate.
No. Increases the implantation rate. Pregnancy rate increases, but ongoing pregnancy and live birth
Pregnancy
are
rate.
the same.
Okay.
Okay.
Okay,
So
ma'am.
I'll correct that line, Dr. Pooja. I'll correct that for my next lecture.
I've not been using hyaluronic acid. तो आपके lecture का मुझे लगा एक बार try करना चाहिए अगर live birth rates are improved with it.
These are
And the embryo glue, I
right
think most of
examples.
the people, embryo glue, I
Yes.
think most of the people
We
are
have
using.
used and we have stopped using also, no?
Stop using it. That
We
has
have
only
also, we
hyaluronic
had,
acid.
I mean,
So thank you, Dr. Jyoti, for a very elaborative, very beautiful talk on
Right.
embryo transfer technique. Can I say
thank you
something?
so much.
Can I say something?
Yeah,
Yes.
definitely.
I think you have covered most of the points. I think you have covered most of the points. It's one of the most important steps during the process of IVF. And I think all of us should actually make it a point to mark out these patients where we are expecting difficult embryo transfers or where we found stenosis cervix even during hysteroscopy. And even after treatment or whatever AKT or whatever treatment of stenosis DOS, I think wherever you feel the patient is very jittery, the patient is not going to allow or it's going to be difficult, maybe when you want to arrange for anesthesia, preferably arrange for anesthesia during the daytime and beforehand. It really helps it. And as we know, difficult transfers are to be avoided to achieve maximum pregnancy. That goes a long way in improving outcomes. Thank you.
I think this was Dr. Prabjot. Dr. Lakshmi, you want to say something?
Yeah, so Dr. Jyoti, it was a very good elaborative talk. And I just wanted to ask if, like, normally I use plasma infusion on a routine basis and also a tocilizumab, but I'm not using GCSF on the day of embryo transfer. So what is your, like, the study says that they have a better, like, the results are better with the GCSF. So what is your experience with GCSF?
I also have no experience. It was just during this talk that I could come across these positive, what all helps us. So I have not personally I have never used GCSF at the time of embryo transfer. Some people use a little bit of HCG though at that time, a very micro dose of HCG. I also don't have any personal experience about using that. If anybody has, we can all share on this platform because this is the platform where we can all learn from each other. So if anybody has that sort of experience, one can just unmute yourself and say, because I have no, I also have not used ever GCSF at the time of transfer.
Ma'am, we have been, hello ma'am.
Yeah, hi
Wonderful.
Dr. Isha.
Hi ma'am, and a wonderful lecture. Ma'am, we have been using GCSF, but not on the day of ET. We have been using it while we are preparing ET.
Yes, yes.
So, yeah. But
that actually we have all been using when we,
but not on the day of ET.
we use GCSF, we use a little bit of PRP with GCSF, so we can use any combination just to improve the endometrial thickness. But this was written at the time of embryo transfer, which actually I think one has to read more studies about it. Then only we'll comment on this. But yeah, that you are right.
And
we used to
I am
use
using routinely at
HCG.
the time of ET, madam. And 7 to 8%
What,
is GCF. I am giving subcutaneous and routinely at the time of ET, and 7 to 8% results have improved.
Oh, wow. So this is okay. So you use one GCSF subcut at that, how much before ET? Sir, unmute कीजिए.
ET किया और साथ ही साथ इंजेक्शन दिया, टेबल पे और भेज दिया.
Okay.
So basically it is a post embryo transfer. After embryo transfer, we are giving the GCSF, and 48 hours before also we are giving GCSF. The purpose is to improve the endometrium only. And sometimes the patients are responding, but in one batch it appears they are responding, and second time we are saying the same thing that it may not be necessary. So, but it comparing with PRP, GCSF is doing better results than PRP.
Ma'am, how much you are giving? 300 or 150?
We are giving 300.
300.
We were using intrauterine. We were using HCG 2 to 3 hours before. 2 to 3 hours before an embryo transfer. and we used to dilute the 2000 HCG.
Sir,
it
only
comes-
single dose. Okay, you are only single dose you are using at the time of transfer, or you are repeat it or before the transfer also?
I'm using GCSF 48 hours before the transfer and then after embryo transfer.
Fair
2
enough.
times.
Okay, okay.
Why
ma'am.
is
Full
only
300
during
dose, ma'am?
at only one dose at the
Okay.
time of ET?
And 300, sir. Full.
हाँ
300.
300 ही दे रहे हैं हम लोग.
Okay, okay.
But this is worth trying.
Yes.
GCSF.
We'll try, ma'am, next
So-
time.
Also,
we
ma'am, I
can-
just wanted
we
to
can
ask
do
one
that.
question to Dr. Sharayu, if she's there. What about, ma'am, or your experience, what about ultra short protocol in poor responders?
Dr. Sharyu,
Hello.
Hello?
Yeah. Can you
Yeah,
repeat the
Dr.
question?
Yeah. The ultra short GnRH agonist protocol for the first 3 days in poor responders.
Yeah.
What is your experience on that?
Ma'am, we had tried for patients who are having borderline AMH, which is in patients who AMH was less than 1.5. In those
Correct.
patients, we have tried when we had given Lupride 0.5 ml from day 7 days prior to the expected menses, and then we stopped. Like, to be honest, it has same result what we practice the antagonist protocol. The only thing is synchronization is better, but in terms of live birth rate, the antagonist protocol and the stop agonist GNH protocol works similar way. Doesn't have much difference.
No, Dr. Shreya, I'm asking about the ultra short. That is for the first 3 days. When the
Okay.
period starts.
Okay, I was
Yeah,
sorry. I
yeah.
was thinking you are asking about ultra short
No.
agonist protocol. Again, the fear of dropping the LH very low, and then we are starting with the. To be honest, I don't remember in last my 3 years where I used ultra short protocol for any of the patients, because initially when we started using, we had very less oocyte yield. FOI was very less, so we completely stopped this ultra short agonist protocol. But with ultra short protocol, I think there will be more of premature LH surge, so there will be more chances of premature rupture of the follicles. The main thing is when we are starting with very, very low LH pool, that is one drawback of that. And we won't add antagonist immediately. So again, it will be either a flexible antagonist protocol, and as you rightly pointed out, the LH surge can be more, and premature LH surge will be more in those patients. So again, the oocyte yield is going to suffer in those patients. So that's what I'm saying. To be honest, I don't even remember when I have used this ultra short agonist protocol.
And what about the use of letrozole in PORs with gonadotropins?
Ma'am, in letrozole, there are many studies being published. It is letrozole will be having additional effect only on the gonadotropin, decreasing the gonadotropin dose over total gonadotropin dose of the stimulation. Otherwise, it doesn't have any additional side effect. Because if you see, letrozole maximum times we have used in patients who are in fertility preservation, in oncofertility, where we have to suppress their estradiol level if the patient is suffering. But there was a paper published in 2020 which talked about if you give letrozole in your ovarian stimulation, they have observed the oocyte morphology in this particular patient. The oocyte morphology was very poor. In that particular study, sadly, they had not talked about the live birth rate, because it was all oocyte freezing study. It was not related to live birth rate. But whenever there is letrozole in your stimulation, because letrozole is decreasing your estradiol level, the main substrate of the follicle is estradiol. That is a mitogenic hormone, and that is improve the oocyte competence of the particular follicle. But by giving letrozole, it may harm the oocyte morphology, and in terms of that, outcome also. So letrozole in stimulation, we don't use unless until it is a oncofertility, because it is just have an effect of decreasing total gonadotropin dose stimulation, but no major effect in terms of live birth rate.
So, Dr. Shiru, do you use clomiphene citrate?
Yes, ma'am. Clomiphene citrate in poor and resistant patients, that's better also, because the gonadotropin stimulation dose, even if you give adequate dose, this will be one more additional thirst of the FSH, and that will definitely have better impact. So clomiphene citrate for 5 days we use for POR patients.
Okay.
Yeah.
So I think that was a wonderful interaction that we had today. Are there any questions?
Dr.
I think
Jyoti,
there are
one
any
question is
questions.
like doses and timings of atosiben before ET.
Yeah. So, anybody using atosiben before ET? Because atosiben is quite, I think, costly. It is 1 dose, half an hour to, I think it prior to ET,
Half an hour prior to ET.
37.5. हाँ,
No, no.
कितना I think I'm forgetting the dose. One is 8.75 करके strength है, and that we use half an hour to 1 hour before so as to relax the uterus. But that is not very costly also, and can in cases where we feel there are recurrent failures, it can be used. Otherwise, proper dose is quite higher dose that needs to be given, and 1 or 2 cases only I've tried atosiben, but the otherwise the studies do say that it is quite it will help. One can, if the patient can afford, if she has repeated failures, one can start atosiben 1 to 2 hours prior to doing a embryo transfer.
So
Give it slowly.
I am using it routinely.
Okay.
It is 6.75 milligram, which is 0.9 ml. So we give it a slow IV intravenous bolus doses given just half an hour, 1 hour before the embryo transfer. And normally it is quite well tolerated. I haven't seen any side effects with it, and it leads to uterine quiescence. And the endo waves sometimes we see in the transfer is reduced with the help of atosiben. And it is not.
You are using that just bolus, not in as an infusion.
No. It is bolus.
Bolus.
Slow IV. Yeah, over 1 minute. Slow IV given.
Right. So I think that was for the today we call it a day, and thank you so much our chairpersons. Dr. Lakshmi, would you like to formally just say a vote of thanks to all our chairpersons and everybody's?
Yeah. So first of all, Dr. Shari, big thanks to Dr. Sharayu to accept the last minute call and to deliver such a wonderful and exhaustive talk on the surprises at IVF. And I would like to thank all the chairpersons for the talk. Also, Dr. Jyoti to giving us such an exhaustive, wonderful talk. And also, I would like to thank all our chairpersons for this talk as well. I would also like to thank that's Jagsonpal Pharmaceuticals, and would like to look forward for another such webinars in which we do a lot of interaction and learn a lot of new things, and and increase and keep on enhancing our practices. So thank you all of you for the wonderful interaction and the wonderful participation.
Thank you so much.